All right, picture this. You're at the grossing bench, and a fresh adrenalectomy specimen gets plopped down in front of you. It's got that classic yellow, nodular look, and right away, your brain just kicks into overdrive. Is this just a simple, benign adenoma they found by accident, or is this a really aggressive adrenal cortical carcinoma? The surgeon, the oncologist, the patient, they're all waiting on you for that one crucial answer. So, how do we tackle this systematically?
I mean, this is it, right? This is the fundamental question. The difference between benign and malignant in the adrenal cortex can be so subtle. But the implications of your call, they're massive. You get it right, the patient gets the exact treatment they need. You get it wrong? Well, that's exactly why we have a standardized game plan.
And here is our guide, our roadmap. The CAP protocol for adrenal carcinoma is our absolute best friend in this scenario. It takes us step by step from that first look on the gross bench all the way to the final sign-out. And it's not just about getting the diagnosis right. It's about making sure we report it in a way that's crystal clear and super useful for the entire team taking care of the patient.
Okay, so let's start with the basics of this challenge. Section 1 is all about setting the stage.
First thing you absolutely have to know, this protocol covers everyone. It's designed for adrenal cortical carcinomas in all age groups, from the tiniest pediatric patients all the way to adults. And you'll see in a minute why this is so critical, because the rules of the game can change dramatically depending on how old your patient is.
So let's head over to the gross room. This is where our investigation really kicks off. Before we even section the tumor, there are huge clues you can pick up just by looking, weighing, and measuring.
First up, weight. And this one is a big one. For an adult patient, if you see a tumor that weighs over 100 grams, you need to have alarm bells going off in your head. It's not a hard and fast rule, but you should be thinking carcinoma until proven otherwise. Most of your benign adenomas, they're way lighter than this.
And right along with weight, you've got size. That 5-centimeter mark is a critical line in the sand for adults. A tumor that's bigger than 5 centimeters, even if it looks totally contained, is automatically classified as at least a PT2 lesion. So the moment your ruler slides past 5 centimeters, the stage of the tumor has already gone up a notch.
All right, we've got our gross clues. Now it's time for the fun part, putting those slides on the microscope. This is where we confirm our suspicions and make that definitive diagnosis. And we do it using some very specific scoring systems.
First, let's talk about the different flavors this can come in. The World Health Organization breaks it down into these 4 main subtypes. Honestly, most of the time you're going to see the conventional type, but you've got to keep the others in the back of your mind, like oncocytic or myxoid, because they can have their own little quirks.
Now, for your adult patients, this table is everything. This is the Weiss scoring system. Think of it as a 9-point checklist for malignancy. You go down the list, looking at everything from how ugly the nuclei are, to the mitotic rate, to different kinds of invasion. And here's the magic number, a score of 3 or more. Once you hit 3, you've crossed the line into a definitive diagnosis of adrenal cortical carcinoma.
But what if your patient is a child? Well, you have to throw the Weiss system right out the window. For pediatric cases, we use a totally different tool, the Wiener criteria. Just look at the parameters. The cutoffs for weight and size are way higher. And for this one, the magic number isn't 3, it's 4. You need a score of 4 or more to predict that the tumor is going to behave badly.
And this just perfectly shows why one-size-fits-all absolutely does not work in pathology. For adults, it's all about the Weiss score, and relatively smaller sizes and weights are big red flags. For kids, it's the Wiener criteria, with much beefier thresholds and a different scoring system altogether. It really shows how you have to tailor your approach to your specific patient. Okay, so you've made the diagnosis of war zone carcinoma in an adult, but you're not done yet. There's another really important step. Mitotic grading. See, this isn't about diagnosing the cancer anymore. We've already done that. This is about prognosis. We have to count the mitoses and split the tumors into low-grade versus high-grade, using that cutoff of 20 mitoses per 10 square millimeters. This tells the oncologist how aggressive this thing is likely to be.
So, diagnosis? Check. Grade? Check. What's next? Staging. We need to figure out how far the tumor has spread. And for that, we turn to the universal language of cancer pathology, the AJCC-TNM staging system.
So the staging journey starts at PT1. This is pretty much the best case scenario for a carcinoma. It means the tumor is small, 5 centimeters or less, and it's still playing nice, completely contained within the adrenal gland itself. No invasion into the surrounding fat or anything else.
Now we jump to PT2. What's changed?
Only one thing: size. The tumor has now grown past that 5 centimeter mark, but, and this is the key part, it's still confined to the adrenal gland. It hasn't broken out yet. At PT3, the game changes. The tumor has broken out of the adrenal gland. Size doesn't matter for this stage. It could be small or big, but it's now invading into the surrounding fatty tissue, or maybe into the renal vein. The important distinction here is that it has not yet grown directly into its neighbors, like the kidney or the liver.
And that brings us to PT4, the most locally advanced stage. Again, any size tumor can be a PT4, but now it has taken that aggressive step of directly invading adjacent organs, chewing into the kidney, the spleen, the pancreas, or it's gotten into major blood vessels like the vena cava. This is a whole different level of bad news.
Okay, we've done it all. We've done the gross exam, the microscopic diagnosis, the grading, and the staging. So what's the last piece of the puzzle? It's putting all of that amazing work together into one clear, standardized document, the synoptic report.
Now, part of putting that report together involves ancillary studies. You know, our H&E slides are the workhorse, but sometimes you need to call in the special forces, immunohistochemistry. We use SF1 to prove it's actually from the adrenal cortex. We use K67 to see how fast the cells are dividing, which is a huge prognostic factor. And stains like P53 and beta-catenin can give us clues about underlying mutations that often mean a more aggressive tumor.
Let's just focus on SF1 for a second, because this stain can be an absolute lifesaver. If you have any doubt at all about where this tumor came from, maybe it's a metastasis and you're not sure of the primary site, SF1 is your go-to stain. It is by far the most reliable marker we have to say, yes, this is definitely from the adrenal cortex. And this is the final product. Every single piece of data we've gathered, the size, the weight, the Weiss score, the grade, the stage, the IHC results, it all gets neatly plugged into the CAP synoptic report. This checklist format makes sure we don't miss anything, and it gives the clinicians a clear, easy-to-read playbook for patient care. It really is the gold standard.
So there you have it. We went from a confusing yellow blob on the gross bench to a complete, standardized, and totally actionable report. Yeah, the journey is complex, but the CAP protocol gives us the structure we need to nail it every time. So the next time that adrenalectomy shows up, you'll have the roadmap. The only question left is, are you ready to hit the road?